I'm very pleased to introduce my colleague and friend Lisa Marsch as the first speaker today. Lisa's an associate professor here in psychiatry. She's the head of the Center for Technology and Behavioral Health, and she's the head of the Dartmouth Psychiatric Research Center. And one of our most fortunate decisions over the last 30 years while I've been here has been to reach out and recruit Lisa to come to Dartmouth. She's really just the kind of leader that we were looking for, and she's been inspirational to all of us in the 3 years that she's been here. So it's my pleasure to introduce Lisa.
Okay, good morning, everyone, and welcome. It's terrific to see everyone here. We're so excited about the day's events and a really great set of speakers and discussion and hopefully engagement with all of you on this topic. Seth and I were just chatting about it would be great to hear who's in the room, and we're wondering how many folks are addiction treatment providers in this space. Great, good to have you here. And what about mental health treatment providers? Okay. Terrific. Researchers? Many familiar faces. Other clinicians that I didn't mention? Okay, welcome. And community members? Any students? Great. Prevention folks. Any prevention folks? Oh, excellent. Well, we have a really nice mix in the audience, and it's great to have you here. I hope we can have really good discussion today as the day progresses. I'd like to thank Seddon in particular for inviting me, but also inviting many of the faculty and affiliates of our Center for Technology and Behavioral Health to be involved in this meeting today and to present a lot of the research that's happening in this space and to have a discussion with all of you. And I'm going to kick off the morning with a bit of an overview of the state of the field of applying technology to behavioral health. So thinking about what's the state of the science of applying web and mobile technologies to not only substance use disorders and treatment and prevention around that, but also in the mental health space. So I'm going to give a bit of an overview of what's the sort of promise of this approach in this arena and what are the data generally showing from research in this space and clinical applications of these tools. And then to talk a bit about what opportunities there might be for the future in terms of scaling up the work and the implementation of effective therapeutic tools that are technology-based that target behavioral health. So I'll start with this sort of big picture overview, and then we have a wonderful lineup of speakers today who will cover the full spectrum of development and evaluation and implementation and sort of sustained use of these tools in lots of different contexts. So we have an exciting day ahead of us. So first, I'd like to acknowledge some research support for some of the projects I'll be mentioning, which was largely from the National Institutes of Health, including the center that Seddon mentioned, which is a center grant from the National Institute on Drug Abuse. I'd also like to mention that in addition to my academic affiliation, I have an affiliation with a small business that has been involved in developing some technology-based therapeutic tools. So let's start off by talking about the promise of this approach. Why are we thinking about technology? Why are we thinking about mobile phones in the context of addiction treatment, for example? So when you think about mobile technology and the internet, it's transformed virtually everything about our daily lives, right? So the way we do retail, the way we do travel, the way we do our banking, even the way we meet other people and interact with folks socially, even meet significant others, right? There's all kinds of new models to do this online, remotely, securely, conveniently. And I think that similarly, there's a real opportunity to think about how can we leverage these tools and the ubiquity of these tools in the healthcare space, and particularly in the behavioral health space. And what I'd like to suggest to you today is that the data are increasingly showing with careful scientific research that that technology also offers great promise for really changing service delivery models, healthcare service delivery models, and behavioral health service delivery models, in increasing the quality of care delivered, increasing the reach of care, the personalization of care, and in doing it in a way that can be cost effective. And there are lots of different applications of this. I'll give you some examples as we go along here, but there are lots of applications sort of in terms of clinical populations, right? In terms of folks with problematic substance use, with mental health problems, folks that have other kinds of chronic illnesses that need to be managed. But also there's lots of activity in the space of mobile health focused on wellness promotion. And sort of what some call the quantified self movement, really around tracking data about yourself and your own behavior that can really increase self-knowledge via data. And we'll hear a little bit about that. In fact, one of our next speakers, Andrew Campbell, who's a professor here in computer science, has been doing some really exciting work in that space. So the work is spanning the whole spectrum, from prevention and assessment to treatment, and all kinds of sort of interventions focused on behavior change to recovery support. And here are some examples of some of the applications of these approaches. So in the assessment arena, there's a lot of interesting and exciting research focused on using technology, including mobile devices, for data collection. And that offers increased standardization in the way data are collected. There are lots of projects that have shown that it increases accuracy of data collection. And what's pretty exciting about this also is that you can get data continuously or in a wide array of settings and in real time. So it really offers unprecedented levels of access to sort of real-time information about individuals' behavior and symptoms and functioning, and on and on. And so there's lots of opportunities to think about how those data can be used in clinical space. And you'll hear some great examples of that in the presentations today. In the intervention space, there's a lot of exciting work in the prevention space with children, with adolescents, with young adults, focused on prevention of risk behavior and using interactive personalizable tools around that. Lots of exciting work in the behavior therapy space, interactive behavior therapies that are designed to help people make changes in self-defeating behaviors that they may wish to make changes in. Self-learning tools, self-management tools, heavy focus on skills training, on initiating and maintaining new patterns of behavior, on setting and tracking progress toward goals. And these aren't just sort of patient or client-facing tools. There are lots of exciting ways you can think about the application of technology to an extended support network. So to parents and family members and clinicians, and thinking about care coordination models and thinking about data sharing and therapeutic support in entirely new ways, which can include decision support tools. It can include new applications of social media, for example. And it really offers an opportunity, I think, for a consumer-centric approach in healthcare delivery that we haven't seen in quite the way that I think we could see with the help of technology in our service delivery models, and really the opportunity to engage consumers and help them be heavily involved in sort of primary drivers in their own health behavior. So here's some potential promises of this approach. One is reach. We know that there are a number of evidence-based interventions and tools that can be helpful to people in treatment and recovery. But there are challenges in access to some of these interventions. And so one of the exciting aspects of technology is the ability to promote widespread dissemination or widespread access to effective therapeutic tools, right? You can centrally deploy these things and promote access in lots of different contexts and settings. And so that is a real strength and relates in part to what Bob was saying earlier about, even though we might have some, terrific treatment models, they're not accessible to everyone who could benefit from them. And so we can really think of creative ways to extend the reach of our care network with technology. There are also opportunities to think about quality of care delivered. We know there's a lot of variability in terms of therapeutic support that's offered in different contexts, and we can be assured that with technology-based tools, they'll work the way that they're designed to work, so we can ensure fidelity in the delivery of the intervention. Really exciting opportunities in the space of personalization. You can develop these tools to be responsive to all kinds of different characteristics of an individual, their needs, their preferences, their level of cognitive functioning, There are cultural considerations. You can really have tools that are very adaptable and modifiable for different populations. We've spoken a bit about engagement and really the opportunity to have tools that can engage people in new ways. And as Bob mentioned, this opportunity for sort of on-demand access, 24/7 access to tools that may be helpful. So someone might feel at risk of relapse to drug use at 2 a.m. on a Saturday night, and they may not have access to their clinician at that time, but they might have something available right there online or on a mobile device that could be helpful to them in getting through that. There's also some interesting data that are evolving showing that if you provide tools that provide sort of in-the-moment assessment and then interventions that are responsive to what people's needs are at a given moment in time, you can prevent costly escalation of problems and unnecessary healthcare utilization around that. There's also some interesting work highlighting the opportunity to think about technology and reducing stigma and disparities in healthcare access. There's, perhaps surprisingly, the technology is being accessible in many, many populations, but even among the most vulnerable and disadvantaged populations with whom we work, even among homeless populations, even among persons with serious mental illness. And so there's a real opportunity to think about how do we leverage this access to these tools and provide support to these individuals and do it in a way that can help reduce some of the disparities that we see. There are also some opportunities to think about models of service delivery that centrally integrate technology so that you increase service capacity, right? So if you sort of offload some of the service delivery model to a technology-based system, you may be able to see more individuals with the same number of resources, clinician resources, and financial resources. So I think as we look collectively at research in this space, it seems like if these tools are developed well and are studied carefully, there's a real opportunity to think about scaling them up and considering their implementation in a wide array of settings that can really have a population-level impact. So we've spoken about this a bit, but just a few statistics about how prevalent these devices really are. The trends all go in the same direction, increase access all over the world. Globally, about 90% of folks have mobile devices, sometimes more than one mobile device that they're carrying around. And the estimates currently are about 6.8 billion folks globally have mobile phone subscriptions. And many of those are smartphones, and smartphones, as you may know, are different than sort of feature phones or flip phones in that they have really extraordinary computational capacity and allows for all kinds of exciting things in addition to internet access. And the stats are also showing that smartphone access is also growing all over the world. And as I mentioned, this is true, and there are lots of data showing this is true even among the folks with whom we work on a regular basis, persons with behavioral health issues and folks who may be impoverished and in rural settings and lots of vulnerable communities. So this slide summarizes generally what the research field is showing right now in terms of the utility of these tools. And the pattern of results generally shows that if you develop these tools well, and I'll stop there for a second to say that's really important how you develop these tools and how you develop them in a way that they really bring value to the end user and drive engagement and have some utility to the person or persons using them. And I hope that during our discussion today we'll have a chance to talk more about optimal models of development. But if you develop these tools well and in collaboration with your target audience, you can get findings like these. You can get high acceptability, high utility among lots and lots of different populations, from children to adolescents to aging populations to chronic drug users to folks with psychotic illnesses and on and on. We see that you can have a large impact on health behavior and on health outcomes. Some studies that have directly compared technology-based interventions to traditional models of service delivery have shown that you can often get comparable outcomes with technology-based interventions to what you see with clinician-delivered models, and sometimes better outcomes, particularly in settings where you don't see evidence-based practice being provided. You see increased quality, reach, and personalization of care. There is growing literature on underscoring the cost effectiveness of these models. And also some really exciting work around how these tools can be modified over time to really be personalized in a way that they're responsive to individuals' clinical trajectory over time. Lots of exciting work with interdisciplinary teams of computer scientists and engineers and behavioral scientists. So let's just for a second talk a little bit about the prevalence of mental health and substance use disorders. And these stats will not be unfamiliar, I think, to anyone in this room. So we know that these are significant problems. The estimates vary, but generally about 1 to 4 to 1 in 5 folks in the US are said to be diagnosable with a mental health disorder, and about 1 in 10 with a substance use disorder. And we know that this has huge impact on people's lives in terms of their functioning, in terms of their ability to hold jobs, in terms of their social and family relations, and in terms of their cost to the healthcare system. So there are estimates that the annual economic cost of mental health problems is over $300 billion, and this has been increasing in recent years. The World Health Organization estimates that mental illness accounts for more disability in developed countries than other groups of illnesses. This includes even cancer and heart disease. So a really significant set of issues. So not only is mental health a significant issue in its own regard, but mental health problems hugely impact the entire space of health and wellness, including chronic disease management. So we know that behavioral health problems fairly frequently co-occur with other types of more sort of medical conditions. So one example of that is the co-occurrence of diabetes with depression. Persons with diabetes have, the estimates are between 40 to 72% incidence of depression and about 50% incidence of anxiety. So these things cluster together, and when they do, we see worse outcomes. So we know that all chronic physical health conditions require some health behavior change, and we know that the course of the management of these medical conditions is largely impacted by behavioral health problems. And here's some examples of what the research in this space shows. Lower quality of life when you see these co-occurring, poorer response to treatment, worse medical outcomes, worse psychiatric outcomes, higher mortality, and higher cost of care. So just to go back to this example of depression and diabetes, when these things cluster together, we see that healthcare costs increase by 50 to 75%. So as Bob mentioned earlier, we're in this interesting time in healthcare in this country where we're having lots of reform under the Affordable Care Act, and as part of that healthcare change, we've seen that there's, among other considerations, a focus on integrated care. So integrating behavioral health and sort of more traditional medical care. And so as a result of what's happening in terms of healthcare reform, as a result of what we know about the intersection of these phenomena and how they impact each other, it seems like there's a tremendous need, and it's a really interesting time to think about how can we as a healthcare system be responsive to this? And it strikes many of us who work in this space that there's a real opportunity to think about technology as part of the solution. Not only the solution, I don't think it's the solution to all of our healthcare problems, but I think there's a real opportunity to think about how can we use these tools to promote integration of effective care and to do it in a way that can meet the needs in terms of integrated care, to do it in a way that can address some of the challenges we have in insufficient workforce to do this, and to do it in a way that really can provide improved models of care. So I'd like to talk a little bit about ways you could think about applying these tools. I think there are lots of creative ways we could think about accessing these tools as additional tools that are available to us, that we can make available to clients, and to improve service delivery models. And I think that the research community has really only scratched the surface of really what is possible in the application of these tools. But I'll give you some examples of models that have been tested, and then show you just some examples of data highlighting these different models of deployment. So one model that you could consider is you could consider these tools as a supplement to traditional treatment, right? So this is an adjunct to care model. So it's an additional tool in the toolbox of clinicians they can make available to their clients. Their clients can access these tools when they're not with their clinician. So almost sort of like homework or things that they can use in between sessions with a clinician. Some people have been calling this a clinician extender model. So it's sort of extending the reach of clinicians, extending the impact they can have even when they're not working directly with their client. So it can extend the impact of clinician-delivered therapy. It can be used as an adjunct to various types of medication-based treatments as well. Other models have looked at sort of a replacement model or a partial replacement model, where these tools partially replace a portion of traditional care. And so what's the benefit here? Well, some treatment systems have felt that this could be useful in expanding their service capacity, which I mentioned briefly earlier. So if they have, for example, long wait lists and they don't have enough resources to accommodate the need that they've got, perhaps they could see more folks if they had an integrated model where part of the care was delivered by interactive, personalized behavioral interventions delivered via some technology platform and integrated into what the clinicians were doing in that setting. Some other settings have found it helpful to think about this kind of deployment model in that it may free up clinicians to have more time to focus on clients who have greatest need. So clients in crises or clients who really need more time from the clinician, they have incredibly high workloads in some of these treatment settings, and this might free up some more time if they could have this integrated model of care. And then yet another option is just a standalone intervention, right? That maybe these are offered outside of treatment settings. Direct-to-consumer kinds of tools, and this might be particularly relevant in rural settings. It might be relevant to folks for whom access or interest in our treatment models is absent, right? So, Bob spoke earlier about the majority of the folks that have behavioral health problems in this country are not in our treatment systems. There's a tremendous opportunity to think about how do we engage that population. Perhaps we can provide some tools directly online to them. And there's some early stage research showing that in some of these direct-to-consumer models, in some cases that can function as a conduit to treatment entry. So for the first time, people might enter some of our treatment systems after having done some sort of self-management work with some of these tools. Okay, so I thought I'd show you a little bit of data to illustrate some of these deployment models. So this is just one tool of many. There's a lot of exciting research in the space of technology applied to substance use, applied to mental health. You're going to hear about a lot of that today. This is one tool that I mentioned because it's been studied in some of the deployment models that I just mentioned, and I thought I'd illustrate some of these different applications so you can get a sense of how you can deploy these tools and what kinds of outcomes you can see in doing so. This particular tool is it's basically an interactive behavior therapy. It's grounded in a certain model of behavior therapy that has been shown to be effective, called the community reinforcement approach. There's a central focus on skills training, lots of different skills listed here as examples. There's a real central focus on initiating and maintaining new patterns of behavior that don't involve problematic substance use. So it's really finding value and meaning in other things in life that don't involve substance use. So it's an interactive system. It has 65 different components to it. It's intended to be used as an ongoing sort of therapeutic support tool. And it's wedded to this model of behavior therapy that has empirical support and then also employs certain informational technologies that have been shown to be important in promoting acquisition and long-term retention of skills. And it's available on many different platforms, desktop computers, Android, iPhones, iPads, etc. So here are some sample screens. I'm not going to go into a lot of detail about the tool. If folks are interested, we can discuss it later. It's more just to highlight an example of an application in this space. Here are some examples of the different sections of the program. Some skills training, some psychoeducational content, some interactive videos, some interactive processes to understand individual risk behavior and such. So here's what the general research shows from work with this system. There have been studies that have looked at this partial replacement model that I described briefly, where part of clinician-delivered therapy has been replaced with this interactive treatment for substance use disorders. And that research has shown that you can see outcomes that are as effective as outcomes delivered by therapists who are highly trained in delivering this behavioral intervention. And the reason that's important is that this is not about replacing those therapists. We don't have enough of those therapists. And so it's really around thinking about, are there active ingredients in this? Can this have an impact? And then to think about how can this be deployed in a way that can help improve people's lives. There's also research that basically has shown that if you partially replace or add it as a supplement to sort of standard community-based treatment, which we see in many community systems around the US, we can actually see better treatment outcomes, in some cases high as doubling of rates of abstinence from substance use. And there's also some evidence showing cost effectiveness in different addiction treatment settings. So here are the models of deployment. So here are data that illustrate some of these models that I was describing to you. This study was sort of it's called an efficacy trial, which means that really tight control over sort of manipulating all the different conditions in this study. It's not really done in community systems. It's done in a highly controlled sort of academic setting where you randomly assign people to different study conditions and look at the outcomes. So in this particular trial, there are 135 folks entering outpatient addiction treatment. This one happened to be folks seeking Suboxone treatment for opioid addiction. And there were 3 conditions. Let's see if we've got a pointer here. Yeah. So in the red bar, this was an intervention that was heavily done by this interactive behavioral treatment. The blue bar was comparable effective behavior therapy delivered exclusively by clinicians, the same model of treatment that was done by the computerized system, but done entirely by clinicians. And then the third bar was standard addiction treatment in these types of opioid treatment settings. And these data suggest, and this is just one example, but this is objectively measured urine testing of opioid and cocaine use. And what we saw in that study was that we saw comparable outcomes in terms of abstinence from these substances when you offload a lot of the intervention to a computerized intervention versus when you delivered exclusively by a clinician. And both of these evidence-based practices were better than standard treatment. So now this slide shows a different sort of model of deployment, and this is more of an effectiveness trial, which is really working with the community and thinking about if you change a model of service delivery, what are the outcomes? And so this happened to be in a methadone maintenance treatment program, 160 folks entering treatment there, tracked for 12 months. And there were 2 conditions. You either went into standard methadone maintenance treatment, right? So you go in, you receive methadone medication on a regular basis, you receive some counseling in that context. And the second condition was a modification of that treatment model in that half of your therapy sessions were done with your counselor, but the other half were done on the computer. So you reduced the clinician contact in half and offloaded that to the technology-based intervention. We find that when we reduce treatment as usual in half and replace it with technology, we actually get better abstinence rates. And there are lots of potential reasons for this. Perhaps it's around the personalization of the interaction. And the clinicians, we have lots of data from the clinicians in this and the administrators. And these are treatment settings where clinicians have 50 patients on their caseload. And so if they could have a model where they can get better outcomes and have more time to spend with clients in need, this might bring value in that kind of a treatment system. I'm going to skip over this just in the interest of time. This is an example of a comparative effectiveness trial. Now, this is a different model of deployment, a direct comparison between exclusively technology-based intervention, exclusively clinician-delivered intervention. And this was done in prisons. And in prisons, as you may know, there are very high rates of problematic substance involvement in folks who are incarcerated. There's a long history of that. Among 80% of inmates report problems with substance use prior to incarceration. And yet prisons often have very limited resources to provide even the most basic drug education to folks who are incarcerated. So for this system, there was some value in a design where they could learn if all we've got is a technology-based intervention that folks can use, and we don't have access to clinicians to come in and really meet the need in this context. What do the outcomes look like with that model? And so that's why this comparative effectiveness design was conducted in that context. 10 prisons around the US, and it was a longitudinal study where we looked at, we recruited folks while they were incarcerated, and then we looked at outcomes post-prison release, so 3 and 6 months after they got out. What happened after they got out of prison? So this slide shows substance use, high rates in both the computerized in blue and the counselor-delivered models at baseline, and comparable reductions in substance use post-prison release across the two arms. Similar pattern in criminal activity. We also saw similar patterns in things like documented reincarceration rates, et cetera. So this is an illustration of a design where perhaps this could be useful as a standalone intervention when you don't have resources for anything beyond that, and you have a tremendous need for this type of intervention. Okay, one more example of a deployment model that I'll mention, and this illustrates the model where you think about providing these tools as a supplement to care, as an adjunct to care. So it enhances what's already being provided in a treatment setting. This was a small study. We have a larger one running now, but this was 50 folks entering outpatient addiction treatment. And it was random assignment to one of two conditions. So either you went into standard outpatient addiction treatment, this one happened to be methadone maintenance treatment, or when you came in and entered methadone maintenance treatment, you got a cell phone. And on that phone was an interactive, personalized behavior therapy system that can help you sort of, as you move about your daily life, in helping you in your treatment and recovery. And so we looked at what happened for the first 3 months of treatment entry. So in general, we saw decent feasibility and acceptability. People used it. We didn't have too many sort of lost phones. We had good data usage rates around it and high levels of reporting of liking and utility. And we had a lot of qualitative data we collected in this that indicated that folks use these tools at times that seem to be clinically meaningful. So this study was done in New York City. As an example, we had a woman who indicated that she has to go to the Bronx every weekend, and said that had historically been a high-risk environment for her. And so she told our research team that every Thursday night before she had to go to this setting, she went through a self-management planning routine on her mobile device to help her remind her of her commitment to treatment and to strategize about how she could be successful in not relapsing when she went to the Bronx. So the qualitative data were promising, and the quantitative data were also quite promising. So this graph shows the percent of participants retained in addiction treatment in that treatment entry phase, the first 3 months of treatment entry, when they do or do not have access to a mobile phone as part of treatment. So when we give them this simple tool when they enter treatment, we saw that it increased retention in treatment quite a bit. 84% in this arm versus 56% who didn't get it. And then we also looked at drug use outcomes with urine testing, and we saw this seem to translate into drug-taking behavior as well, where we saw a trend for greater weeks of abstinence from opioids, the target substance that folks were entering treatment for in methadone maintenance treatment, when you got the mobile tool versus when you did not. So these were very promising data and suggest there might be some utility in thinking about this simple tool as an adjunct to our traditional models of care. Okay, so just a few concluding points here. I think that there's a lot of really exciting work being done in this space of technology and behavioral health. I've tried to review through some of the patterns that we're seeing emerge when you really have science drive the development and the evaluation and the implementation of these tools. But I think there's a lot of really exciting opportunities as we move forward in this field and really thinking about how do we take this science, how do we take what we're learning and really have a public health impact, a population level impact. And I'd like to talk just briefly about some ideas around this in the space of development of these tools, in the space of evaluation of these tools, and in the space of implementation of these tools. And this is really for some of the presenters to think about as well. As you work in this space, there's some really under sort of studied areas that I think there's a real opportunity for us to study more carefully and learn more about as we sort of scale up the science and really think about changing behavioral healthcare systems via technology. So the first one is really ensuring that our clinical considerations and sort of healthcare system considerations drive how we use these tools. You know, I think there are gadgets popping up all the time, new sensors being developed, all kinds of technological advances happening on a daily basis, really, in this space. And I think that I think for us as researchers, it's been really important to think about what are the clinical aims, what are the goals around this, how can technology be a tool to forward those aims, and let the clinical priorities drive the use of the tools. I also think there's a real opportunity for us to think about breaking down some of the silos in what we do, right? We know that, as we spoke about earlier, you know, these problems don't occur in a vacuum, right? Substance use often co-occurs with other mental health issues, which often co-occur with other sort of chronic disease considerations. And some of the aspects of what's effective in promoting behavior change transcends sort of disorder type or population type. And I think technology can really help us break down some of these silos and create, you know, systems and integrated suite of tools that can be responsive to whatever combination of needs and preferences people present with. And so I think we should really think about not just a tool for X or a tool for Y, but really think about the person and the person's needs and priorities, and then what can be offered to them in this model of service delivery. And that relates to the third point here of really having this consumer-centric focus in the development process. The data in the development space have highlighted repeatedly the importance of consumers really defining and shaping all kinds of aspects of the tool, not only its content, but its functionality, the interface, and on and on. And I think that is something that we shouldn't lose sight of as we think about the evolution of research and development in the space. Another point that I think it would be great for us to talk more about today in our discussion time is research focused on better understanding of mechanisms of behavior change. So we've seen some really promising research showing these tools can work, but we don't have a really solid understanding about how do these tools work? How do they best drive change? And I think that it would be really helpful if we had a real focused line of research thinking about what are the mediators of change? What are sort of the target criteria that we need to reach in order for a tool to actually then translate into behavior change outcomes? And I think if we really had a good understanding of those criteria, it would help us understand this broader literature, which sometimes shows effects of these tools and sometimes not. So there might be some criteria there that really are sort of our targeted outcomes in this, and it would be really helpful to know that, as well as do we see differential patterns of mechanisms of behavior change with technology-based tools relative to our traditional models of care. You know, given how accessible they are, how personalizable they are, there may be some differences in the rate and or the nature by which they drive behavior change, and it's an important and understudied area. And then finally, in the space of development, I think it's really exciting a lot of the work that's evolving in computer science and engineering around predictive modeling and really learning about individuals' behavior and changes in individuals' behavior over time. And I think there's some really exciting work that some folks here will talk about. Andrew Campbell from computer science, Rachel Bryan, and Dror Ben-Zev have been doing some exciting work in this space, really trying to understand how can these tools evolve over time with the individual, and how can they change up the offering based on the needs and priorities of the individual at a given moment in time. And I think it's a whole new way of thinking about personalized health care and thinking about ways we can improve quality of care. So in terms of evaluation, I think there are lots of exciting opportunities as well for us to consider, including the way in which we do our evaluations. We see a lot of randomized controlled trials in this space, which is terrific, but I think there's lots of opportunities to still have experimental rigor, but learn things perhaps more quickly about this type of model of delivery, including some exciting evolutions in measurement, in experimental design, in data analytics, and in data visualization. And this really underscores the importance of an interdisciplinary team in development and in evaluation of these tools. I also think it would be really exciting to see more research in more sort of community implementation models. So really looking at if you integrate these tools into systems of care, not only how do they change service delivery and outcomes, but what are all the cost considerations around that? How does this impact payer systems? How does this impact healthcare spending and perhaps down the line savings in healthcare? And I think we have a real need to do some real careful research around this. Another issue that I think has been understudied, and I would encourage many of you who work in this space to think about it, is what are the important ways in which people might use these tools, right? So I think we often see that tools are offered to some clinical population, and they're told, we suggest that you use this twice a week for 12 weeks, or 3 times a week for 24 weeks, or whatever the model is. And if they don't quite do that, it's considered sort of non-adherent. And I don't know that the data really show that those models of adherence are critical to drive outcomes. In fact, the data that have been published in this space are sort of equivocal. And there's some evidence that might suggest that you don't need to promote use of these tools every day for the rest of your life for every population. It might be that if indeed these tools do what we hope they do, which is help people learn certain skills, help people expand personal and social resources that can promote behavior change, perhaps that becomes part of their behavioral repertoire, and perhaps that becomes part of what they do, and they don't need access continuously to this, but perhaps they might want sort of booster sessions or sort of strategic, episodic use of these after sort of developing that skill set. So I think it's a really important and understudied area of research that we could look at. And then I'll just conclude here in a couple of minutes and just talking about some exciting opportunities, I think, in research and clinical application in the space of deployment and sort of the implementation of these tools. So we've talked about some of the research that's looked at models of deployment, but I think it would be exciting, again, to think about some real-world sort of models that we could test as part of demonstration projects around this, including perhaps a prescription model. So a model where, not unlike a provider providing a prescription for a medication, providing a prescription for access to one of these systems that may be useful for folks in their care. There's also some early stage but interesting work looking at models of care where you sort of promote implementation of these systems in various care settings, but then you have sort of a centralized support team that can support the integration, the adoption, the ongoing use of these tools in that context. So rather than every program having to have in-house someone who understands all of the nuances about implementation, around the infrastructure needed for that, around the privacy, security considerations, et cetera. Perhaps there are models where you can have some centralized resources that can provide support to a broad community around that. We've spoken a bit about the direct-to-consumer model. That's really underdeveloped in terms of sort of scaled-up models in research around this. That I think that there's lots of opportunity for that. This issue of minimally disruptive healthcare is a concept that I first learned of from a colleague at Mayo, Victor Montori. And the idea is this, that when you have a medical condition, when you have mental illness, for example, the illness itself is very burdensome. But the treatment for that illness is also very burdensome. Right? So you have to go to lots of appointments, you have specialists involved, you have tests involved, you have a bunch of medications involved, you have to manage that whole spectrum of what often is complex treatment regimen, particularly if you have comorbid, medical conditions on top of the behavioral health problem. And so this concept of minimally disruptive healthcare is really trying to think about how to help folks create a much more manageable treatment regimen. And I think the technology offers a tremendous opportunity to think about that. How can we reduce the burden of treatment with the use of these tools? Not only in promoting self-management, but maybe medication taking reminders, maybe care coordination types of tools. I think there's a lot that can be considered around how can we use these tools to help folks not only in recovery, but really doing it in a way that minimizes the burden of some of that. 2 final comments. There's a lot of exciting work going on in academia. There's a lot of exciting work going in industry. These things don't always meet. So it's really interesting to think about some new partnerships, right? So academic, industry, commercial, government partnerships, where you have a model where the academics can really drive the science behind the development and the creation of these tools in a way that they're really going to produce the intended outcomes. You have sort of foundation and industry partners that are there and committed to the deployment and the scaling up and sort of the ongoing life of tools that work, right, which the academics often are not able to do with grants, for example. And then the government partners who really can help in a regulatory space and promoting sort of guidelines around best practices based on the science around this. So I think there's some real opportunity to think about new partnerships in this space. And then finally, in the global health space, there's a lot of exciting work as well. I've talked a lot about US-based research thus far, but we talked about some of the stats showing the ubiquity of access to these tools in the US, there are striking statistics, but they're even more striking when you look at lots of low and middle income countries. So even countries that haven't developed landline infrastructure, they all have mobile phones, and sometimes more than one, and often have, in some of these countries, underdeveloped behavioral health systems. And so there's a real opportunity to think about how can we consider in various cultural contexts, again, harnessing the use and the access to these tools in a way that can help people improve their lives. So I'll stop there. The final slide is our website. Seddon did a beautiful job, thank you, of sort of providing a summary of our research center. We have the privilege to work with a tremendous group of researchers and advisors, many of whom are sitting in this room. It's a great privilege to work with all of you, and we've got a lot of exciting work happening. So check out our website, and I'm looking forward to a great discussion today. Thanks so much.